Okay, doctor, so let's try again. I don't know. Can you hear me now? Can you hear me? Um, is it better? I think we'll just go through with this, okay? I don't know what to do. After this, we can look at how to get, yeah, let's just go. Okay, so what we've got to understand is that in between episodes, the child may appear normal, and that can make the diagnosis a bit tricky. Okay, so the full triad that you want to look at is abdominal pain, a mass, a child with Curran jelly stool, and usually that occurs in less than 15% of cases, because I said that that red Curran jelly stool that many people talk about, most of the time it is the latter part of the intussusception, when there are some small breaks in the lining of the intestine and things are really going bad. Okay, now there are some atypical presentations you also have to learn for your exam, okay, where the child can present with lethargy or altered consciousness only, and they may not have any pain, but that is a bit far-fetched. Okay, that's a bit far-fetched. And it can also, intussusception can also mimic sepsis or meningoencephalitis. And even in older children, they may have only pain without bleeding or mass. And in infants who are less than 3 months, they may have no pain at all. Now, so let me share my screen. So let's talk about the investigations. Always remember, for intussusception, ultrasound is the first line. Okay, abdominal ultrasound is the first line, where nearly it's about almost 100% sensitivity and specificity, and you see what we call a target or bull's eye sign. And then you can also do what we call fluoroscopy, but usually the fluoroscopy is used for diagnosis and therapeutic enema. Okay, and then you can also do a CT scan, which is reserved for unclear diagnosis. So in a board exam situation, your first line diagnostic test is ultrasound. When do you do CT scan? It is reserved for patients who have an unclear diagnosis, or if you want to assess for lead points. And the concern here is that, remember that most cases of intussusception is in children, and so you want to be very careful about the CT scan radiation these kids are receiving. All right, the CT scan radiation that these children are receiving, you want to be very, very careful about that. Okay, so this is an ultrasound which is showing intussusception. Okay, and this is how it looks like. That's a target sign, or the bull's eye. So you see that on the ultrasound. Now, ultrasound is always going to win. Why? Because it can detect pathologic lead points. Ultrasound does not need any radiation. It can detect rare types of intussusception, and it can also even guide you with reduction. So ultrasound can really do that. So on ultrasound, remember, you're looking for the target sign, and for CT scan, you are looking for complicated or uncertain cases. That is when you do your CT. But remember that in CT scan situations, you are exposing a child to a lot of radiation. Okay, so now let's do this question. And for our friends who are trying to join, who cannot join, please just send them the YouTube link. Okay, just send them the YouTube link. What I'll do is I will also do my best to send the YouTube link on WhatsApp as well. Those on Facebook, please send them the YouTube link on Facebook as well, because I can't stop the class now, and can't stop it now and now share all those things. So just share the YouTube link. I'll share the YouTube link in the comment section, and then you can share it with them. So yeah, okay, so this is the YouTube link. I'll share it in the WhatsApp groups as well. Yeah, good. So please, let's solve this question on the board. Let's solve the question on the board now. Let's solve the question on the board. So a 9-month-old previously healthy boy is brought to the emergency department with a 6-hour history of episode, with a 6-month history of episodic inconsolable cry. Now, during which he draws his knees to his chest, he has vomited twice, initially non-bilous, but now bilous. Between episodes, he appears relatively normal. His last two was yesterday and was normal. Vital signs are stable on exam. You note a soft abdomen with no palpable mass. Which of the following is the most frequent diagnostic test? I think we've read about this. Is it A? Is it B? Is it C? Is it D? Or is it E? And we all know the next diagnostic step will be to get an abdominal ultrasound. Ultrasound is the first line test for suspected intussusception. It's non-invasive, medication-free, and we get almost 100% sensitivity and specificity. The ultrasonographer is experienced. Remember that CT scan is not the first time. We use CT scan when ultrasound is non-specific, right? That's when we use CT scan. And CT scan also has, high levels of radiation as well. Now, next question. You have a 1-year-old boy who presents with intermittent episodes of severe abdominal pain. And now, his parents describe that he suddenly cries in pain, then seems well in between episodes. There is no diarrhea or fever. On exam, the child is pale and intermittently unresponsive. Which of the following is the most specific clinical finding for each exception? A. Bilous vomiting. B. Current jelly stool. C. Lethargy between episodes. D. Positive stool, occult blood. And E. Intermittent inconsolable cry. Intermittent inconsolable cry. So the following is the most specific clinical finding for intussusception. The answer is B, right? That's so we're looking for specific things. Current jelly stool, even though it is late, that is a specific finding. Remember, we talked about the triad of symptoms. I want to go back again. Current jelly stool. So if you remember, the child will have cramping pain, crying, current jelly stool, vomiting, which earlier is non-bilous, but later there's it progresses to bilous, and then there's a mass, right? That's what you are tested on, and that is the correct answer. Next question: you have a 2-year-old girl who presents with vomiting abdominal pain. An ultrasound reveals a target sign in the left upper quadrant, and the lesion measures 2.5 centimeters. The child is stable and has no mass or blood in the stool and is mildly symptomatic. What's the next step? A. Immediate air enema reduction. B. Surgical exploration. C. Repeat ultrasound after a short interval. D. CT scan to identify the lead point. And E. Administer glucocorticoids to prevent recurrence. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? Ultrasound reveals a target sign in the left upper quadrant and the lesion measures 2.5 centimeters. The child is stable, has no mass of blood vessel, and mildly symptomatic. What's the next step? A. Immediate air reduction. B. Surgical exploration. C. Repeat ultrasound after short interval. D. CT scan to identify the lead point. And E. Administer steroids. And the correct answer is C. Now, in a non-ileocolic intussusception, remember, in ileocolic intussusception, the pain or the target sign will be in the right lower quadrant, right? Now, this is something I'll be going there. This patient's target sign is in the left upper quadrant. It's like it's in the colon itself. It's a colocolic intussusception, right? Most of the time, the regular interception is ileocolic. Usually you find it in the right lower quadrant. This is found in the left upper quadrant. Okay, so a non-ileocolic interception, which is less than 3 centimeters, with minimal symptoms, is life transient. Most of the time, observation with repeat ultrasound. So this is something you need to know. It's a hard fact. If you don't know it, you go ahead and say, "Oh, let's just do the pneumatic reduction." But because it's a non-colic interception and it is less than 3 centimeters, you can just observe because most of the time it will just come out on its own. That's a hard fact. No worries about that. So air enema is for ileocolic intussusceptions. Okay, air enema is the ileocolic intussusception. Surgery is premature without worsening symptoms. So let's look at treatment approach into most patients who present are stable. Okay, so what you do is that if they are stable, you just do your ultrasound. It confirms ileocolic intussusception. If there is no perforation, the patient has no hemodynamic instability, you treat with non-operative reduction, and the non-operative reduction is either air or liquid. If the child is acutely or has signs of perforation, so they may have rigid abdomen, very tender abdominal palpation, then what they do is that they require urgent surgical intervention. And when we also do urgent surgical intervention, it's also indicated if expertise for non-operative reduction is unavailable. So if the child is stable, like the first point, no perforation, hemodynamically stable, treat with non-operative reduction. If the child is acutely ill with perforation and requires, then that means that that child requires urgent surgical intervention. Now, there's another whole thing, small bowel intussusception. That one is managed differently. And at the time, small bowel intussusception can resolve on its own. The main intussusception we are focused on in this lecture is the ileocolic one. The ileocolic, because that is in about 90% of cases, right? Now, what are the non-operative reduction techniques? We can use either saline or we can use air enema. Okay, and that's the best type for ileocolic intussusception. Okay, and Dr. Ruj, I'll just go ahead with the class. Okay, we've gone back and forth with the sound thing. Let's just go ahead with the class. And it requires stabilization, surgical backup. So if you are doing the pneumatic reduction or you are using saline to deal with the interception, the first line in ileocolic interception is either using fluid or using air. Okay, but when you are doing, you want to make sure that there's the backing of a surgical team, such that if that fails, the surgery can be done. Okay, and with the hydrostatic or pneumatic management, it is done without sedation. You can do it without sedation. Now, what about ultrasound or fluoroscopic guidance? Ultrasound is preferred because you want to avoid radiation, and it can help to detect lead points. Okay, fluoroscopic use either hydrostatic or pneumatic. And how do you know that an interception has been managed properly? Assuming you pump the, assuming you give the fluid, how do you know that it has been solved? Number one, there's the disappearance of that mass. Okay, there's a disappearance of that mass, and then number two, there's a free flow of contrast into the terminal eye, and you realize that that child who was complaining of abdominal pain, the pain has resolved. All right. Now, what are the risks and complications of interception? The main risk of interception is perforation. That's the main risk of interception is perforation. And what are the risk factors of perforation? Number one, if the child is less than 6 months, if there's prolonged symptoms, and if there's signs of obstruction, then there's the likelihood that there can be perforation. And pneumatic reduction, that's using air, has smaller perforation risk, less contamination. So if you are torn between all the ways of doing it, using air is seen to be very good. Now, what's the success rate? In expert centers, your success rate is about 70% to 85%. And you see more success rate in pediatric cases. And the success rate reduces in children who are less than 1 year or who are more than 5 years. Okay. And pediatric reduction is generally more effective than using the fluid. So you can just use the air, go through the rectum, and the pediatric surgeons know what they do, and the child is born. Now, there's also what's called delayed repeat, where it is used if partial reduction is achieved. You try to reduce it and only partial reduction is achieved. Then you can do delayed repeat enema, where you can repeat the enema again. And you avoid it if initial attempt showed no movement or if the child is unstable. If the child is unstable, take the child to the operating room. Okay? Now, after you've done the procedure, what do you do? This is another thing you want to pay attention to. In intussusception, the only time you give antibiotics is when there is sepsis or there's perforation. After you've managed the patient, you can start them on clear fluids and you can advance the fluids as the days go by. Most of the time, you can discharge them within 2 hours if they are asymptomatic. And follow up is prompt. They should probably return to the hospital if the symptoms are okay. And it is advisable that the doctor follows up with that child in 1 to 2 days. Okay. Now, can each session repair? Yes. In about 10% of cases, mostly within weeks to months. And about 4% of them also can repair within 48 hours. And there is no contraindication to non-operative reduction or the child is unstable. Okay. And most of the time, you want to review the pathologic lead point, especially if um, there's recurrent um, episodes. So when do you go for surgery? When do you go for surgery? When do you go for surgery? The child is unstable, there are signs of tinnitus, or if there's any perforation. And when do you also go for surgery? If you try the non-operative measures and they don't work, then you can go for surgery. Or you can do surgery if there's suspected mass lesion and it is not responding to conservative management, which is using the air or using the fluid. Okay? So I'm not going to waste your time on small bowel intussusception. That's usually resolved spontaneously. So that's small bowel intussusception. Forget about like that's not necessary. The one we are focusing on is ileocolic intussusception, which occurs in about 90% of cases. So let's read some questions here. I think because of the sound, I will not be reading them. Just look at them and give me the answer. Okay, you have a 13-month-old boy who presents um, to the emergency department with a 24-hour history of intermittent abdominal pain and one episode of billows. Is currently stable equilibrium and its abdominal exam shows mild distension with focal tenderness in the right upper quadrant. Now, ultrasound confirms ileocolic intussusception. Your facility has expertise in non-operative. What's the most appropriate next step? A, immediate exploration laparotomy. B, intravenous antibiotics followed by ultrasound monitoring. C, non-operative reduction with air enema under fluoroscopic guidance. D, intravenous corticosteroid about edema. E, observation and ultrasound instruments. So what's the answer? Is it A? Is it C? Is it D? Or is it E? And the correct answer is C, non-operative reduction with air enema under fluoroscopic guidance. So C is the correct answer because we've already done a whole lecture on that about the fact that that is what you do. But when you're doing non-operative reduction, you should have surgery waiting just in case that fails. The surgeons can move. Good. So you have a 10-month-old infant undergoes an air enema for intussusception under fluoroscopic guidance. During the procedure, the radiologist notes free air under the diaphragm on post-procedure film. The patient is dynamically stable but developing increasing abdominal distension and tachypnea. What's the next best step in management? A, initiate broad spectrum antibiotics and observe. B, immediate surgical consultation and NG nasogastric compression. C, repeat enema in 30 minutes. Sorry. D, administer glucagon to relax colonic smooth muscle. And E, discharge home if stable in 2 hours. So the correct answer is B. You want to immediately consult surgeons and pass an NG tube because it looks like this patient has developed perforation. That's why they have air under the diaphragm, right? And so immediately the surgeons should come in and they should. But while you're waiting for the surgeons to come, you want to pass your NG tube to start decompression. In this patient, part of your management plan is that you may need to give some antibiotics, and then the surgeons can come and take over and go do their miracles in their surgical theater. Okay. So you have a 5-year-old boy who presents the second episode of Intussusception within 3 months. He's currently stable, and the prior episode resolved with air enema. Okay. Ultrasound again shows ileocolic intussusception. What's the most appropriate next step? Second episode. A. Proceed directly to surgical resection. B. Attempt non-operative reduction again and review for a lead point. C. Begin glucocorticoids to prevent further recurrence. D. Observe for spontaneous reduction only. And E. Discharge home and advise follow-up only if symptoms worsen. The answer A. Is it B? Is it C? Or is it D? Okay. So the answer is B. We learned that you can attempt non-operative reduction if it recurs. Next one, during hydrostatic edema and ultrasound for ileocolic intussusception, the intussusception disappears and water is visualized entering the terminal ileum. What does this indicate? A. Severe failure. So S should be used instead. B. Complete reduction of intussusception. C. Presence of persistent pathologic lead points. Need for immediate to confirm reduction. E. Partial reduction requiring surgical follow-up. What does it mean if you are doing sort of an intussusception and the intussusception disappears, but you see water entering the terminal ileum? What's the correct answer? The correct answer is B. It means there's correct reduction, okay, of the intussusception. So B is correct. And disappearance of the mass flow of contrast and air or saline into the terminal ileum confirms that there is complete reduction. Complete reduction. Okay. So let's do some active recall. Now we're just going to make sure that what we learned sticks. So let's do some active recall. But before that, I want to remind you that we have a mock exam on May 7th. That is this coming Wednesday. Okay, 200 MCQs. They are timed, 3-hour session. And so if you get in touch, I'm going to get you the link and you can use that to register. It's remotely proctored and you have an invigilator looking after you so you can take the mock. As well, I also want you to understand that our course is going on this evening. There's going to be a class. You have your points line upon line review. You have 14 classes every month, at least 3 hours, and then you get to do more exams. And you even have a question bank as well in the portal where you can do some mocks. That's about 1,200 questions. And then you have the personal interactive study portal. Okay? So the study portal has all these portals, so you click on it, and then you go and study. In the class, you're going to get your line upon line review. You're going to get your 14 classes every month, at least 3 hours each. You're going to get 42 hours of total live tutoring every month. Okay, you're going to get mock exams, your personalized interactive study portal, and then you're also going to get your med bullets. Now, med bullets, as you all know, is every 10 minutes you have one topics you are reviewing. So that means every 1 minute you are reviewing a high yield point in one topic. And so you can just replay it. It's like we review everything with you over and over and over and over again. It's like actually having me as Dr. Bobby as your study guide or a study partner. And we are working through, points upon points upon points that you need to get going. Now, someone is asking, what's the time for the mock? It's at 6 p.m. EST, 6 p.m. Ontario time on Wednesday. Okay, so all this is going for only $2,199 Canadian, not USD. So it's there for your taking. Join us. Let's get into it. Okay, Now, so let's do active recall of intussusception. Quick question. At what age does intussusception mostly occur? At what age does intussusception usually occur? Just type in your answer. Let's go. Type in your answer. At what age does intussusception usually occur? So I'm trying to add this to our learning so that it becomes very easy. Good. Dr. Sukrin says 4 to 36 months. That's powerful. That's it. 4 to 36 months is when it usually occurs. Beautiful. Let's move on to the next one. In which age group should you be more concerned about an underlying? In which age group should you be more concerned about an underlying lead point? Type in your answer. Let's go. Type in your answer. Let's go. In which age group should you be more concerned about an underlying? Good. So less than 3 months and more than 5 years. Okay. Children who are less than 3 months and more than 5 years, you should be more concerned about an underlying point. What's the most common type of intussusception? 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 Good. Ileocolic. Ileocolic. Okay. What viral infection is most strongly associated with idiopathic intussusception? What viral infection is most commonly associated with idiopathic intussusception? What viral infection is most commonly associated with idiopathic intussusception? Good. Adenovirus, especially type C. Good. Good. People are picking it up. Thank you very much. I'm very happy about the answers I'm seeing. Okay. What's the most common pathologic lead point in children? What's the most common pathologic lead point in children with intussusception? What's the most common pathologic lead point in children with intussusception? Most common pathologic lead point. Good. Good. Merkel's diverticulum. Merkel's diverticulum. What's the classic triad of intussusception? Classic triad of intussusception. I want to know. What's the classic triad of intussusception? Classic triad of intussusception. What is it? I'm waiting for answers. Type. Cramping abdominal pain. Okay. I see that. Episodic abdominal pain. Okay. Runs too. Sure. So intermittent abdominal pain, palpable sausage-shaped mass, and the current jelly stool. Okay. Classic triad of intussusception. Intermittent abdominal pain, palpable sausage-shaped mass, and current jelly stool. Okay. What unusual presentation might confuse intussusception with sepsis or encephalopathy? What unusual presentation might confuse intussusception with sepsis or encephalopathy? And I think that one is if the child becomes lethargic or becomes altered mental status as an isolated. Okay. Good. Now, what's the first line image of suspected intussusception? Is it X-ray? Is it CT? Is it fluoroscopy? What is it? What's the first line imaging for suspected intussusception? First line imaging. Beautiful, 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 beautiful. Ultrasound. Ultrasound is what a lot of people are saying. Sensitivity and specificity approach 100% in expert hands. Okay. What imaging should be avoided for diagnosis alone due to poor sensitivity? What image? I didn't really come out on that a lot. What imaging should be avoided for diagnosis alone due to poor sensitivity? The answer is X-rays, abdominal X-rays, because the sensitivity of abdominal X-rays is less than 48%. CT scan is on this. You do the CT scan, if abdominal ultrasound fails, or if you want to find the lead point and you're not very sure. But I should show this in the class. Abdominal X-rays, the sensitivity is less than 48%. Okay. When is CT scan used in diagnosis of intussusception? When do you do CT? You request for CT scan for the diagnosis of intussusception? When do you diagnose CT scan, or when do you use CT scan in the diagnosis of intussusception? If the ultrasound is inconclusive, or you want to characterize a suspected lead point, you can make it for something, then you can do CT scan. So if ultrasound is inconclusive, okay. And what is the treatment of choice for stable with ileocholic intussusception and no perforation? Stable ileocholic intussusception, no perforation. What's the treatment of choice? What's the treatment of choice? What's the treatment of choice? Stable children, ileocholic intussusception, no perforation. What's the treatment of choice? What's the treatment of choice? So you can do air enema or fluid enema. So pneumatic enema or hydrostatic under imaging guide. Okay. All right. Which reduction technique has slightly higher success rate? Is it air or hydrostatic? Is it air or hydrostatic? Which reduction technique has slightly higher success rate? Is it air or hydrostatic? And the answer is air, or we call it pneumatic. Beautiful. When is surgery indicated in intussusception? When is surgery indicated in intussusception? When is surgery indicated in intussusception? Doctors, don't forget to like and smash the subscribe button. Okay. When is surgery indicated in intussusception? When the child is unstable, when there are signs of perforation, when non-reduction fails. Okay. When the child is unstable, perforation, and non-operative reduction fails. Are antibiotics needed after successful enema reduction? Do you give antibiotics? Oh, this child was very sick. Do you give antibiotics after successful enema reduction? Do you give antibiotics? I want to know. Do you give antibiotics, yes or no, after successful enema reduction? Good. So this comes under choosing wisely, right? Choosing wisely. There's a whole website called Choosing Wisely Canada. If you've not reviewed it, please go back, go to www.choosingwiselycanada.com. Those in MedCognito, there's a whole 230 MCQ questions in your portal, where we design questions for you on choosing wisely courses. What's the main risk of non-operative reduction? What's the main risk of non-operative reduction in intussusception? What's the main risk of non-operative reduction in intussusception? What's the main risk of non-operative reduction in intussusception? What's the main risk of non-operative reduction in intussusception? Bowel perforation, 1 to 4%. Dr. Ronnie Lankela even gave me the percentage. Powerful. That's good. And which technique is safer if perforation occurs? Air or hydrostatic? Which technique is safer if perforation occurs? The answer is air, right? It's less harmful. But if there's perforation, you are going to go in anyway. The surgeons have to do a surgical procedure. Okay. So doctors, this is it. Basically, you've got to focus on objectives. That is it. You've got to focus on MCQ on objectives. If you focus on the MCQ on objectives, you're never going to go wrong. All right. And that's why. So someone will say, Dr. Boni, why do you choose the topics you choose? I choose the topics I choose because they're the MCQ on objectives. So remember, you can come in for even just 30 days, or you can come in for 6 months. Just send me a WhatsApp message on +1 3068915649. +1 3068915649. +1 3068915649. Okay, just send me a WhatsApp, and then I'll get in touch with you right away. I'm available if you want to give me a call as soon as this class is done. Give me a call. Don't forget, on Wednesday you have a mock exam. Tonight you have a class. Wednesday you have a mock exam. Thursday you have another class. Then we move on. We move on. Move on. I'm very sorry about the audio. I'm not a very technical person. I'll do my best to look into it. But thank you very much for spending your afternoon with me, despite all the technical challenges. It's always a pleasure to study with you. And as we all get towards, the end, and you know what, doctors, someone may say, so Dr. Boni, you give all this value for free. Yes, 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 yes. So can you imagine those who are in the medical program itself? We wake this morning, we woke them up around 3:50 a.m. to study, and all of them were, a lot of them, I would say all of, a lot of them were up studying. That's it's a family. It's a family with them, and it's great. So doctors want to join the family, just send me a WhatsApp right now. Let's get you enrolled, and let's get a success on the way. Tonight have a class. Wednesday have a mock. Thursday have a class. NAC exam is done. So the next batch of NAC candidates are also going to go. We are preparing the candidates for the May 2025 TDM exam as well. So if you're interested in any of these classes, let us know. You also need help with your CV writing and personal statement, FM Pro C, and all those things. Send me just shoot a WhatsApp message. +1 306 891 5649 will be helpful. Thank you very much, doctors. Enjoy your day, and thank you for spending your day with me. And I'm very grateful that you stuck with us despite the technical challenges. Thank you. Have a wonderful day. Bye-bye. I'll be expecting your calls from anyway.